Chapter 17, Electrolytes, from the Lewis textbook. This is a review from class. Sodium plays a major role in extracellular fluid volume and concentration, generation and transmission of nerve impulses, and muscle contractility. Sodium is the primary determinant of extracellular fluid osmolality, and the serum sodium level reflects the ratio of sodium to water, not necessarily the loss or gain of sodium. Changes in the serum sodium may reflect a primary water imbalance, a primary sodium imbalance, or a combination of the two. Sodium leaves the body through urine, sweat, and feces. The kidneys are the primary regulator of sodium balance. Hypernatremia is not a problem in an alert person who has access to water, can sense thirst, and is able to swallow. Hypernatremia, secondary to water deficiency, is often the result of an impaired level of consciousness or an inability to obtain fluids. Excessive sweating and increased sensible losses from high fever can also cause hypernatremia. Excessive sodium intake with inadequate water intake can lead to hypernatremia. Symptomatic hypernatremia is rare. Symptoms are thirst, lethargy, agitation, seizures, and coma, impaired level of consciousness, and symptoms of a fluid volume deficit. If there is an extracellular fluid volume deficit, symptoms are postural hypotension, weakness, and decreased skin turgor. The primary goal of treatment of hypernatremia is to treat the underlying cause. In primary water deficit, fluid replacement is provided either orally or IV with isotonic or hypotonic fluids such as D5W or half-normal sodium chloride saline solutions. If sodium excess, then dilute the sodium concentration with sodium-free IV fluids such as 5% dextrose in water and promote excretion of the excess sodium by administering diuretics. Monitor serum sodium levels in a patient's response to therapy. Quickly reducing serum sodium levels can cause a rapid shift of water back into the cells, resulting in cerebral edema and neurological complications. This risk is greatest in a patient who has developed hypernatremia over several days or longer. Hyponatremia. This may result from a loss of sodium-containing fluids, water excess in relation to the amount of sodium, like a dilutional hyponatremia, or a combination of both. Common causes are from loss of sodium-rich body fluids include profuse diaphoresis, draining wounds, excessive diarrhea or vomiting, and trauma with significant blood loss. A common cause of hyponatremia from water excess is inappropriate use of sodium-free or hypotonic IV fluids. Now, this can occur in patients with surgery or major trauma or during administration of fluids in patients with renal failure. SIADH would result in dilutional hyponatremia caused by an abnormal retention of water. The clinical symptoms are a result of the cellular swelling and are first seen in the central nervous system. And the symptoms would be like confusion, irritability, headache, seizures, and coma. In hyponatremia caused by water excess, fluid restriction is often the only treatment. If severe symptoms, if they have seizures, small amounts of IV hypertonic saline can restore the sodium serum levels while the body is returning to a normal water balance. Treatment of hyponatremia associated with fluid loss includes fluid replacement with sodium-containing solutions. Drug therapy involves agents that block the activity of ADH, also known as vasopressin. Conivaptan results in increased urine output without loss of electrolytes such as sodium and potassium, and it should not be used in patients with hyponatremia from excess water loss. Tolvaptan is used to treat hyponatremia associated with heart failure, liver cirrhosis, and syndrome of inappropriate antidiuretic hormone secretion, SIADH. Potassium is necessary for transmission and conduction of nerve and muscle impulses, for cellular growth and maintenance of cardiac rhythm. Sources are fruits and vegetables like bananas and oranges. Salt substitutes have potassium in it. Potassium is regulated by the kidneys. Patients may receive potassium from parenteral sources, including IV fluids, transfusions of stored hemolyzed blood, and medications like potassium penicillin. The kidneys are the primary route for potassium loss, eliminating about 90% of the daily potassium intake. The remainder is lost in the stool and sweat. There is an inverse relationship between sodium and potassium reabsorption in the kidneys. Factors that cause sodium retention would be low blood volume, increased aldosterone levels, and this would cause potassium loss in the urine. There are many salt substitutes used in low-sodium diets that contain substantial potassium, and large urine volumes can be associated with excess loss of potassium in the urine. If kidney function is significantly impaired, retained potassium can lead to toxic levels. Although renal failure is the most common cause of hyperkalemia, there are many factors that lead to this electrolyte imbalance. Adrenal insufficiency with the subsequent aldosterone deficiency leads to retention of potassium. Acidosis, massive cell destruction like in a burn or crush injury, tumor lysis, or severe infection, and exercise can lead to a shift of potassium from the intracellular fluid to the extracellular fluid, which would be increasing their serum levels. In metabolic acidosis, potassium ions shift from the intracellular fluid to the extracellular fluid in exchange for hydrogen ions moving into the cell. Digoxin-like drugs and beta-adrenergic blocking drugs like propranolol can impair entry of potassium into the cells, which results in a higher extracellular fluid potassium concentration. Potassium-sparing diuretics, amiloride, aldosterone receptor blockers like spironolactone, or angiotensin-converting enzyme inhibitors like enalapril, lisinopril, may contribute to the development of hyperkalemia by reducing the kidney's ability to excrete potassium. Initially, as the levels of potassium increase, the patient may experience cramping, leg pain, and weakness, followed by weakness or paralysis of other skeletal muscles, including the respiratory muscles. Abdominal cramping and diarrhea occur from hyperactivity of smooth muscle. The most clinically significant symptoms of hyperkalemia are the disturbance in cardiac conduction. Cardiac depolarization is decreased, leading to the flattening of the P wave and widening of the QRS complex. Repolarization occurs more rapidly, resulting in shortening of the QT interval and causing the T wave to be narrower and more peaked. Ventricular fibrillation or cardiac standstill may occur. When the elevation of potassium is mild and the kidneys are functioning, it may be sufficient to withhold potassium from the diet and take potassium out of the IV sources and increase renal elimination by administering fluids and possibly diuretics. Kayexalate is administered orally or rectally and binds potassium in exchange for sodium, and the resin is excreted in the feces. Patients with moderate hyperkalemia should additionally receive one of the treatments to force potassium into the cells. Usually, it's IV insulin and glucose. Sodium bicarbonate is used if the patient is acidotic. All patients with clinically significant hyperkalemia should be on an ECG to detect dysrhythmias and to monitor the effects of therapy. The patient experiencing dangerous cardiac dysrhythmias should receive IV calcium gluconate immediately, monitoring the blood pressure because rapid administration of calcium can cause hypotension. Hypokalemia. The most common cause is abnormal losses from either the kidneys or the GI tract. The GI tract losses of potassium are associated with diarrhea, laxative abuse, vomiting, and ileostomy drainage. Renal losses occur when the patient has a low magnesium level or is diuresing, particularly in a patient with an elevated aldosterone level. Aldosterone is released when the circulating blood volume is low, causing sodium retention in the kidneys with the loss of potassium in the urine. Low plasma magnesium stimulates renin release and subsequent increased aldosterone levels, which results in the potassium excretion. Alkalosis can cause a shift of potassium into the cells in exchange for hydrogen, which lowers the potassium in the extracellular fluid and causing symptomatic hypokalemia. Hypokalemia alters the resting membrane potential, resulting in hyperpolarization, which is an increased negative charge within the cell, and impairs muscle contraction. The symptoms of hypokalemia include changes in cardiac and muscle function. Skeletal muscle weakness and paralysis could occur with hypokalemia, just as it is with hyperkalemia. Hypokalemia initially affects leg muscles. Severe hypokalemia can cause weakness or paralysis of respiratory muscles, leading to shallow respirations and respiratory arrest. Alterations in smooth muscle function may lead to decreased GI motility, like a paralytic ileus, decreased airway responsiveness, and impaired regulation of arteriolar blood flow, possibly contributing to smooth muscle cell breakdown. Finally, hypokalemia can impair function in non-muscle tissue by impairing insulin secretion, leading to hyperglycemia. The most serious clinical problems are cardiac changes, including impaired repolarization, resulting in a flattening of the T wave and eventually an emergence of a U wave. The P waves peak and the QRS complex is prolonged. There is an increased incidence of potentially lethal ventricular dysrhythmias. Treatment of hypokalemia consists of oral or IV potassium chloride supplements and increased dietary intake of potassium. Except in severe deficiencies, potassium chloride is not given unless there's a urine output of at least 0.5 mL per kilogram of body weight per hour. IV KCl must always be diluted and never given in concentrated amounts. Invert the IV bags containing KCl several times to ensure even distribution in the bag. Never add KCl to a hanging IV bag to prevent giving a bolus, and never give as an IV push. The preferred maximum concentration is 40 milliequivalents per liter. However, stronger concentrations may be given for severe hypokalemia with continuous cardiac monitoring. The rate of IV administration of KCl should not exceed 10 to 15 milliequivalents per hour and must be administered by infusion pump to ensure correct administration rate, because patients at risk for hypokalemia and those that are critically ill should have cardiac monitoring to detect cardiac changes related to the potassium imbalances. Because KCl is irritating to the vein, assess the IV sites at least hourly for phlebitis and infiltration. Infiltration can cause necrosis and sloughing of the surrounding tissue, and use a central line when rapid correction of hypokalemia is necessary. The functions of calcium is formation of teeth and bone, blood clotting, transmission of nerve impulses, myocardial contractions, and muscle contractions. Calcium absorption requires the active form of vitamin D, and vitamin D is either ingested in the diet or formed in the skin in the presence of sunlight. Calcium is present in the serum in three forms: free or ionized, bound to the protein, primarily albumin, and complex with phosphate, citrate, or carbonate. Total serum calcium levels reflect the total calcium level of all three forms, although ionized calcium levels may be analyzed and reported separately. Changes in serum pH will alter the level of ionized calcium without altering the total calcium level. A decreased plasma pH, acidosis, decreases calcium binding to albumin, which leads to a more ionized calcium. An increased plasma pH, alkalosis, increases the calcium binding, leading to a decreased ionized calcium. The alterations in serum albumin levels affect the interpretation of total calcium levels, so a low albumin level would result in a drop in the total calcium level, although the level of ionized calcium would not be affected. Parathyroid hormone is produced by the parathyroid gland. Its production and release are stimulated by low serum calcium levels. Parathyroid hormone increases bone reabsorption, movement of the calcium out of the bones, increases GI absorption of calcium, and increases renal tubule reabsorption of calcium. Calcitonin is produced by the thyroid gland and is stimulated by high serum calcium level. It opposes the action of the parathyroid hormone and lowers the level of serum calcium by decreasing the GI absorption, increasing the calcium deposits into the bone, and promoting the renal excretion. HYPOCALCEMIA is caused by hyperparathyroidism in about 2/3 of the cases. Malignancy, especially from myeloma and breast, lung, and kidney cancers, causes the remaining third. Malignancies leading to hypercalcemia through bone destruction from tumor invasion or through tumor secretion of the parathyroid-related protein, which stimulates calcium release from the bones. Hypercalcemia is also associated with prolonged immobilization, which results in bone mineral loss and increased plasma calcium concentration. More rare cases include vitamin D overdose or increased calcium intake, like ingestion of antacids containing calcium, or excessive IV administration during a cardiac arrest. The symptoms are lethargy, weakness, stupor, or coma, decreased reflexes, decreased memory, confusion, personality changes, could be anorexic, nausea and vomiting, obviously some bone pain and fractures, kidney stones, calcium kidney stones, polyuria or dehydration. Excess calcium leads to reduced excitability of both muscles and nerves. The basic treatment of hypercalcemia is promoting urinary excretion of calcium by administering a loop diuretic like furosemide and hydrating the patient with isotonic saline infusion. The patient must drink 3 to 4 liters of fluid daily to promote the renal excretion of calcium and decrease the possibility of kidney stone formation. Other supportive measures include a diet low in calcium and an increase in weight-bearing activity to enhance bone mineralization. Synthetic calcitonin given IM or subcutaneously lowers serum calcium levels. The intranasal form is not effective. Biphosphonates like pamidronate or zoldronic acid are the most effective agents in treating hypercalcemia as a result of malignancy. They inhibit the activity of osteoclasts, and these are the cells that break down bone and result in calcium release. Hypocalcemia can be caused by any condition that results in a decrease in the production of the parathyroid hormone, and this may occur with surgical removal of a portion or injury to the parathyroid glands during a thyroid or neck surgery. Acute pancreatitis is another potential cause of hypocalcemia. Lipolysis is a consequence of pancreatitis, which produces fatty acids that combine with calcium ions and decreasing serum calcium levels. The patient who receives multiple blood transfusions can become hypocalcemic because the citrate used to anticoagulate the blood binds with the calcium. Sudden alkalosis may result in symptomatic hypocalcemia despite a normal total serum calcium level. The high pH increases calcium binding to protein, which decreases the amount of ionized calcium. And hypocalcemia can occur if there's increased loss of calcium as a result of laxative abuse or malabsorption syndromes. A is a Shafostic sign and is contraction of the facial muscle in response to a light tap over the facial nerve in front of the ear. The trousseau is a carpal spasm induced by inflating a blood pressure cuff above the systolic pressure for a few minutes. Low levels of calcium allow sodium to move into excitable cells, decreasing the threshold of action potentials with subsequent depolarization of the cells. This results in increased nerve excitability and sustained muscle contraction, which is how you get the tetany. Excess neuromuscular excitability causes other clinical symptoms like stridor, dysphagia, tingling around the mouth or in extremities. Cardiac effects of hypocalcemia include decreased cardiac contractility and ECG changes. A prolonged QT interval may develop into a ventricular tachycardia. The primary goal of hypocalcemia is to treat the underlying cause. When severe symptoms of hypocalcemia occur, IV preparations of calcium, like calcium gluconate or calcium chloride, are given. Treatment of mild hypocalcemia involves a diet high in calcium-rich foods along with vitamin D supplementation. Oral calcium supplements, such as calcium carbonate, can be used when patients are unable to consume enough dairy calcium, such as those who do not tolerate dairy products. Measures to promote carbon dioxide retention, such as breathing into a paper bag or sedating the patient, can control the muscle spasms and other symptoms of tetany until the calcium level is corrected. Adequately treat the pain and anxiety because hyperventilation-induced respiratory alkalosis can precipitate hypocalcemic symptoms. Phosphorus is the primary anion in the intracellular fluid and the second most abundant element in the body, second to calcium. Most phosphorus is in the bones and teeth as calcium phosphate. The remaining phosphorus is metabolically active and essential to the function of muscles, red blood cells, and the nervous system. The parathyroid hormone maintains serum phosphorus levels in balance, and regulation of phosphate balance requires adequate renal functioning because the kidneys are the major route of phosphate excretion. When the phosphate levels in the glomerular filtrate fall below the normal level or the parathyroid hormone levels are low, the kidneys reabsorb additional phosphorus. High phosphate is commonly caused by acute kidney injury or chronic kidney disease, which results in an altered ability of the kidneys to excrete phosphate. Other causes include chemotherapy for leukemia or lymphoma, excessive ingestion of milk or phosphate-containing laxative, and large intakes of vitamin D that increase GI absorption of phosphorus. Mild hyperphosphatemia is often asymptomatic. The clinical symptoms of a high phosphate primarily relate to the low serum calcium levels often associated with high phosphate levels. These would include tetany, muscle cramps, paresthesias, and seizures. Increased levels of phosphate readily precipitate with calcium, and calcified deposits occur outside of the bones. These metastatic calcium precipitates can be found in soft tissues such as joints, arteries, skin, kidneys, corneas, and produce organ dysfunction, most common renal failure. The management of a high phosphate is identifying and treating the underlying cause. Ingestion of food and fluids high in phosphorus, like dairy products, should be restricted. Phosphate-binding agents or gels, calcium carbonate, limit intestinal phosphate absorption and increase phosphate secretion into the intestine. If hypocalcemia is present, adequate hydration and instituting measures to correct the calcium levels assist with returning the phosphorus levels to normal. With severe high phosphate levels, hemodialysis or an insulin and glucose infusion can rapidly decrease those levels. A low phosphate is rare, but it occurs in patients who are malnourished or have a malabsorption syndrome. Other causes would include alcohol withdrawal and use of phosphate-binding antacids. A low phosphorus may also occur during parenteral nutrition when there is inadequate phosphorus replacement. Acute symptoms would include the central nervous system depression, like confusion and other mental changes. Other symptoms would be muscle weakness and pain, dysrhythmias, and cardiomyopathies. Management of mild phosphorus deficiency may involve oral supplements like Nutrifos and ingestion of foods high in phosphorus, again like dairy products. Symptomatic low phosphorus can be fatal and often requires IV administration of sodium phosphate or potassium phosphate. Frequent monitoring of serum phosphate and calcium levels are necessary to guide the IV therapy. Sudden symptomatic hypocalcemia secondary to increased calcium phosphorus binding is a potential complication of IV phosphorus administration. A reciprocal relationship exists between phosphorus and calcium, and that a high serum phosphate level tends to cause a low calcium concentration in the serum. Low serum calcium levels stimulate the release of parathyroid hormone, which decreases the reabsorption of phosphorus. Magnesium is a coenzyme in the metabolism of carbohydrates and protein and is required for the synthesis of nucleic acids and protein. Magnesium plays a role in maintaining normal calcium and potassium balance, and symptoms of magnesium imbalance are often mistaken for calcium imbalances. Because magnesium, calcium, and potassium balance are closely related, you should assess all three cations together. And alterations in serum magnesium levels profoundly affect neuromuscular excitability and contractility, including cardiac function. Magnesium is regulated by GI absorption and renal excretion. The kidneys are able to conserve magnesium in times of need and excrete excesses. Factors that regulate calcium balance, like parathyroid hormone, similarly influence the magnesium balance. High magnesium usually occurs only with an increase in magnesium intake accompanied by renal insufficiency or failure. A patient with chronic kidney disease who ingests products containing magnesium, like Maalox, milk of magnesia, will have a problem with excess magnesium. The magnesium excess could develop in pregnant women who receive mag sulfate for the management of eclampsia. High magnesium depresses neuromuscular and CNS function. The initial clinical symptoms of a mildly elevated serum magnesium concentration include lethargy, nausea, and vomiting. As the levels of serum magnesium increase, deep tendon reflexes are lost, followed by somnolence, and then respiratory and ultimately cardiac arrest can occur. Management of high magnesium should focus on prevention. Persons with chronic kidney disease should not take magnesium-containing drugs and ingestion of magnesium-containing foods. Those foods would include green vegetables, nuts, bananas, oranges, peanut butter, and chocolate, and all of those should be restricted. The emergency treatment of high magnesium is IV administration of calcium chloride or calcium gluconate to oppose the effects of the magnesium on cardiac muscle. If renal function is adequate, promoting urinary excretion with oral and parenteral fluids and IV furosemide decreases magnesium levels. The patient with impaired renal function will require dialysis because the kidneys are the major route of excretion for magnesium. Low magnesium occurs in patients with limited magnesium intake or increased renal losses. Major causes of low magnesium come from insufficient food intake, including prolonged fasting or starvation and chronic alcoholism. Fluid losses from the GI tract interferes with magnesium absorption. Another potential cause of low magnesium is prolonged parenteral nutrition without magnesium supplementation. Many diuretics increase the risk of magnesium losses through renal excretion. In addition, osmotic diuresis caused by high glucose levels in uncontrolled diabetes mellitus increases the renal excretion of magnesium. Low magnesium produces neuromuscular and CNS hyperirritability. The symptoms include confusion, hyperactive deep tendon reflexes, muscle cramps, tremors, and seizures. Magnesium deficiency also predisposes to cardiac dysrhythmias, like premature ventricular contractions and ventricular fibrillation. Clinically, low magnesium resembles low calcium and may contribute to the development of low calcium resulting from the decreased action of the parathyroid hormone. The primary goal of treatment of low magnesium is to treat the underlying cause. Management of mild magnesium deficiency involves oral supplements and increased dietary intake of foods high in magnesium. Here's our list again, but this time you want them to take it. Green vegetables, nuts, bananas, oranges, peanut butter, and chocolate. If low magnesium is severe or if hypocalcemia is present, IV magnesium sulfate should be given. Monitor the vital signs and use an infusion pump, as too rapid administration of magnesium can lead to cardiac or respiratory arrest.